This is Lee Schwartzberg, and I'm going to give an overview of Breast Cancer 2015. And I'm going to go through a whirlwind tour of breast cancer over the next hour or so and try to touch on all of the topics that may be relevant to the nurses. So let's start by talking about the anatomy of the normal breast. This slide shows a cross-section of what a breast looks like anatomically, and it's composed, as you can see, of multiple lobules, which are here, and which are then connected to ducts, which basically carry milk, one of the functions of the breast during pregnancy and afterwards, towards the nipple. And the microscopic view of a duct is shown here. It is one cell layer thick in the small area and has a basement membrane which keeps it from the rest of the tissue in the breast, or the stroma. And there is a lumen, which is a hole, and this is cut in cross-section, so this is basically a tube. Each breast has 15 to 20 sections, which are called lobes, which are arranged like the petals of a daisy. So you can see that the lobes here are each of them containing areas and sacs that make milk and then feed through the ducts into the nipple area, and where they combine, and then basically you can see little punctate holes in the nipple where the ducts come out and where milk can be expressed. Lymph nodes are attached through lymph channels in the axilla, suprapubic area, and mediastinum and so forth to the breast. The microscopic portion of the breast that makes the duct is called the terminal duct lobule unit, and this is shown microscopically here in a section. So here we're cutting across the ducts, and you can see the lumens, which have some protein pink stain in the middle, but those are actually spaces, and then the ducts themselves, and then sometimes you can see a duct cutting across horizontally, so you can see the whole duct and how it spreads out into the lobule. And the terminal duct lobule is the place where the milk is made, and importantly for breast cancer, it's where breast cancer tends to start. Breast cancer remains a very significant public health problem in the United States. This year there will be 232,000 cases of invasive breast cancer diagnosed. There'll be an additional 65,000 cases of in situ or carcinoma diagnosed, and there will still be 40,000 women who die from breast cancer this year. So it's a very significant problem that we have. Overall, the lifetime risk for breast cancer is about 12.5%, which means if you live to age 90, there's a 1 in 8 chance that you will get breast cancer. And of course, all of us know in our personal lives women who have had breast cancer because it's such a common disease. Some of the good news is that the rate of breast cancer mortality has been declining every year since 1990, and it continues to show to decline up through the current years. So overall, the mortality rate, the number of women who have breast cancer die of breast cancer, has dropped by 1/3 since 1990. And there are many reasons for the reduction in the breast cancer mortality rate, including better screening and early detection. But most people believe that the majority of the reduction in breast cancer mortality is because of the widespread use of better adjuvant therapies and better treatment for women who have metastatic disease. And we'll spend some time talking about that today. Let's first talk about the risk factors for breast cancer. Obviously, the number one risk is gender. Women get breast cancer at a rate of about 100 times greater than men. So we still see some men with breast cancer. There's about 1,500 cases of breast cancer, invasive breast cancer, diagnosed each year in men in the United States. In women, the highest risk factor is actually age. The average age of diagnosis for breast cancer is in the late 60s. And it is a rare disease below the age of 40, and we sometimes have a different sense of that because we see the women with breast cancer and we treat them, and we see women in their 20s and 30s. but actually the risk of getting a breast cancer in your 20s and 30s is very, very small and starts to really rise after the age of 40. There are some women who have a genetic mutation in now many different genes, but the two genes that are most important are the BRCA1 and 2 genes. Or if you have a family history of breast cancer, even in the absence of a genetic mutation or hereditary breast cancer, that increases your risk. A woman who has had a personal history of breast cancer is at higher risk for developing a second cancer. And if there is proliferative disease diagnosed, meaning a breast biopsy that shows atypical ductal hyperplasia or other benign but pre-invasive types of diseases, that increases the risk. Breast cancer is, by and large, an endocrine disease. It's related to estrogen, and we know now for many years that the increased exposure to endogenous estrogen, which can occur in a variety of different ways, increases your risk of breast cancer. So some of the things are early age at menarche, so having your period below age 12 and having a late menopause after the age of 50 or 55, never having childbirth, or a late first pregnancy, and are all factors that basically give uninterrupted periods going for many years, and that in some way increases the risk for breast cancer. In addition, we've recently noted that weight has an impact on that, some of which may be due to the fact that adipose tissue increases endogenous estrogen production. So postmenopausal obesity is a significant risk factor for breast cancer. In days in the past, hormonal replacement therapy was a big risk factor. In the 50s, 60s, and 70s, and 80s, women got hormone replacement therapy very commonly. And women who took more than 5 years of combined hormonal replacement therapy after menopause are at increased risk. That has largely gone away now. And there are other lifestyle and environmental factors, some of which have not been detected yet or discovered yet, but the fact is that those probably are a minority role. Certainly diet, which was thought of a couple of decades ago to be very important, is probably a very minor role in the risk factor for breast cancer. To date, we still don't know a lot of the risk factors, and if you look at women with breast cancer, about half don't have any of these factors. We do know a lot now about hereditary breast cancer. It accounts for about 5 to 10% of breast cancer, most of which is attributable to the BRCA1 or 2 genes, about 80%. Women who have a germline or an inherited mutation in BRCA1 or 2, which they have a 50-50 chance of inheriting from either one of their parents, their mother or their father can carry this gene. If you have a mutation in BRCA1 or 2, there's about a 50 to 85% chance of developing breast cancer over their entire lifetime. And again, that is much higher than the normal population. Most women who have BRCA1 or 2 mutation genes detected opt for prophylactic surgery, which would include bilateral mastectomies with a oophorectomy. The timing of mastectomy and oophorectomy varies between BRCA1 and 2 because the incidence of breast cancer and ovarian cancer varies across these genes. Prophylactic surgery is not the only thing that women can do. They certainly can do chemoprevention and enhanced surveillance, and many women will pick that as well, but the majority of women today do pick prophylactic surgery. Recently, we've understood that there are several other genetic syndromes that can increase breast cancer risk, and we now test frequently for a large panel of genes, typically a 25-gene panel, that includes genes like PALB2, P10, and P53, which account for the other 20% of hereditary breast cancer outside of BRCA1 and 2. How do we make a diagnosis of breast cancer? It starts typically with a core biopsy. This is the best way to make a diagnosis. Core biopsies can be done by ultrasound guidance or by stereotactic guidance. An incisional biopsy is not recommended. Sometimes we still see patients from the outlying rural areas that get those kinds of biopsies, but for many reasons that's not a good thing to do. Ultimately, patients go on to definitive surgery, and we have two major options for definitive surgery: a partial mastectomy, also called a lumpectomy, and a mastectomy with lymph nodes. And we don't have time today to talk much about lymph nodes, but the standard operation on lymph nodes is to start with a sentinel lymph node biopsy, which has replaced an axillary lymph node dissection for the 2/3 to 3/4 of patients who do not have any lymph nodes. And even in women who have 1 or 2 positive lymph nodes, many surgeons are stopping at the sentinel lymph node biopsy, which markedly reduces the risk of developing lymphedema in the arm subsequently. We like to look at several things pathologically, which are very important for prognosis, and we'll talk about them in some detail, and they're listed here in the right-hand column. There are many different types of breast cancer. The pre-invasive type is typically called ductal carcinoma in situ, and this slide shows a representation of what it is. The cells, as I mentioned, of a normal duct are a single cell layer thick, but when they start to proliferate inside the duct and start to occlude the lumen, that's called DCIS if these cells do not look normal. It can be a difficult diagnosis to determine the DCIS versus ductal hyperplasia, which is simply a growth without abnormalities like mitosis, which is seen in this diagram. Eventually, the DCIS starts to encompass the entire lumen and can have different patterns. This would be called a papillary pattern. What's important about DCIS is because it doesn't penetrate through the wall of the duct, it has no chance, if it's truly DCIS, of spreading somewhere else in the body through the lymph channels or the blood vessels. Therefore, surgical treatment or local treatment should be curative in virtually all cases. The most common form of invasive or infiltrating cancer, and those are terms which are essentially synonymous, is invasive ductal carcinoma. This occurs in about 80, or accounts for about 80% of the diagnosis of invasive cancer. And you can see that this also occurs in the terminal ducts. And what's happening here is after the cells can grow inside the duct, they develop the property to penetrate through the wall of the duct and then to go into the surrounding tissue or the stroma where the blood vessels and the lymph channels are. And so therefore the cancer can spread not only to the surrounding tissues in the breast, but through those lymph channels or blood vessels to anywhere else in the body as well. The other relatively common form of breast cancer is called invasive lobular carcinoma. And as the diagram shows, this occurs in the lobules of the breast rather than the ducts, and the cells look different. The lobule itself is important because, or lobular carcinoma is important because it often is mammographically occult. It's hard to see on a mammogram. And the cells under the microscope look like they're in a single file. They can also be difficult to detect in lymph nodes. Generally speaking, the prognosis of ductal carcinoma and lobular carcinoma are similar, though, stage for stage. An important aspect that the pathologist looks at is called the grade of the tumor. And the grade identifies how closely the tumor tissue is to normal tissue. In this diagram, you can see grade 1, which looks more like normal cells that I've shown you. There is some of the ducts have more than one cell thick, but some of them don't, and the normal architecture is relatively well preserved. Grade 2, which is about a third of, or 40% of the grading of breast cancer, still shows some ducts, but the cells look more aggressive. Some of them are larger, some are smaller, and it doesn't look as normal as grade 1. Grade 3 ductal carcinoma looks very atypical. These cells are very active. This dark cell is a mitosis. Here's another one. So these cells are growing very quickly. There's no architecture that looks like the normal breast. You don't see any lobules or ducts at all in this, and this is infiltrating. The importance of the grade is the fact that the prognosis is directly related to the grade, and this is true even when we use other means of determining prognosis, as we'll talk about, like genomic classifiers. And on this slide, you can see that grade 1 patients do better than grade 2 than grade 3, and that's true regardless of the type and of disease. and regardless of the size of the tumor or the number of lymph nodes. We stage breast cancer into 4 stages, 5 stages really, because stage 0 is carcinoma in situ, as I already said, that doesn't spread. Stage 1 breast cancer is generally a tumor that is less than 2 centimeters in greatest dimension and no lymph node involvement. Stage 2 cancers are those that are intermediate size, between 2 and 5 centimeters, or roughly 1 to 2 inches, with or without positive lymph nodes, generally with. Stage 3 cancer is locally advanced and includes many lymph nodes, like greater than 10 lymph nodes that are positive for cancer, or fixed and matted lymph nodes, and large tumors greater than 5 centimeters with lymph nodes. Stage 4 cancer is when the breast cancer has spread anywhere beyond the lymph nodes to distant places in the body, including bone, liver, lung, and brain. There are a number of prognostic and predictive factors for breast cancer, and it's important to understand the difference between these two terms. Prognostic indicators in any disease are factors that affect the risk of recurrence independent of treatment. In breast cancer, prognostic factors include the tumor size, the lymph node status, the grade, the histology, the age of the patient, and certain things that we look at also besides the grade under the microscope, including the estrogen receptor, progesterone receptor, HER2, another protein, Ki67, which is a marker of proliferation that we typically use today. There are also predictive factors in breast cancer and in other tumors. Predictive factors are those that tell you what the response would be to a specific therapy. So they're related to treatment. Sometimes prognostic factors and predictive factors are true for a particular, are both true for a particular factor, and that's true in breast cancer for hormone receptor status, HER2 status, and age. That is, that estrogen receptor is both a prognostic factor, telling you how well the patient will do in the absence of therapy, but also is predictive for particular therapies that block the estrogen receptor, as we'll see. ERPR positive means that we determine with immunohistochemistry that we can see these proteins in the tumor cells, and ERPR negative, we don't see those. About 75% of breast cancer is ERPR positive, so this is the common form of breast cancer. HER2 is a protein that is expressed in all breast cancer cells. We look for an increased amount of expression in HER2 with 2 tests, an immunohistochemistry test similar to what's used for the hormone receptor assays, or a fluorescent in situ hybridization test, also called a FISH test. There are other forms of that that include dual chromogens, so that's called DISH, or chromogenic in situ hybridization called CISH. They're all variations on the same theme of looking at amplification in the actual gene itself, whereas the immunohistochemistry looks at the protein expression of these particular genes. HER2 positive doesn't mean that there is HER2. It means that there's excessive amounts of the gene. If it's HER2 positive by immunohistochemistry, 3+ positive is considered positive in that case. That means there's additional protein than we would expect to see. If it's FISH positive, that means there's amplification of the gene. So they're not exactly measuring the same thing, but they basically are both equally prognostic and predictive. I want to talk for a second about the treatment of breast cancer from a local perspective, because there have been some very interesting changes and trends in the way women are picking local therapy over the last decade. So almost 30 years ago now, or over 30 years ago now, were the first studies looking at lumpectomy plus or minus radiation therapy compared to mastectomy. And these were studies that were, in their day, very challenging to do, because the conventional wisdom was that women needed their breast taken off. They had cancer in the breast. And Dr. Halsted in 1895 came up with a theory that breast cancer spreads from the middle of the breast to the lymph nodes, and then to the farther lymph nodes, and then to other parts of the body. Therefore, if you removed all of the breast, all of the muscles by the breast and the lymph nodes, you would cure more women. It was a great concept. The only thing the only problem with it was that it was wrong, and that turned out not to be true. And that's true in a lot of things that we do in medicine. Things that we take as conventional wisdom today aren't necessarily going to be true tomorrow. Only further studies and experiments can tell us what really works. And so one of those seminal experiments in breast cancer treatment was 2 studies that were reviewed at the 20-year mark, now almost 15 years ago, so 35 years from today, and those were the 2 randomized trials looking at lumpectomy for breast conservation versus mastectomy. And in these 2 studies that were similar, one done in the U.S., one done in Italy, some of them had lymph node positive, they got some modest chemotherapy, and they were randomized to get breast conservation with or without radiation versus a radical mastectomy. And the results were that there was no difference in survival, there was no difference in distant metastases, there was no difference in disease-free survival or other cancers. The survival was the same. In an editorial almost 15 years ago, the comments were made that mastectomy is not superior to breast conservation for the treatment of breast cancer. Only 44% of stage 1 and 2 cancers 30 years ago were actually treated with or 20 years ago were actually treated with breast conservation, and it was felt that it was time to declare the case against breast conserving therapy closed. However, the trend over the last decade in the 2010 era has been for more mastectomy, and particularly more contralateral prophylactic mastectomy. And this is an example of what's been happening in a group of women that have been studied, particularly young women have been doing this. You can see that most young women now are electing for bilateral mastectomies as opposed to breast conservation or a unilateral mastectomy. So this is a very curious trend. It's particularly curious because the risk of contralateral breast cancer has been dramatically reducing over time, much like I showed you the mortality rate, although they're not necessarily linked. So this just shows you that the risk of getting a second breast cancer in a woman who has one breast cancer has actually gone down by over 50% in the last 20 years, probably because of the use of endocrine therapy in part, which also reduces contralateral breast cancer, and also early detection and better screening. So why do we have increased contralateral prophylactic mastectomy in young women? I think there are many reasons for this, and I think they're good reasons. Women have concern about recurrence, but really that concern is more fear than reality, because a new cancer in the other breast is not common, and importantly, there is no survival advantage for getting a contralateral prophylactic mastectomy, even in a young woman, with the possible exception of women who carry BRCA1 or 2 mutation, who are at the highest risk. Outside of that group, there is no survival benefit to getting contralateral mastectomy. I think there are very valid concerns about cosmesis, and I think there are very valid concerns about screening. And much of this comes down to peace of mind when you're making an emotional decision in a time of great stress when you're faced with a diagnosis of breast cancer. We don't understand all of the reasons yet, and this trend is the subject of much research today. So what are the goals of therapy across the stages of breast cancer? Surgical therapy is used to eradicate the disease in the breast and the axilla. In early stage breast cancer, increasingly we're using surgical therapy to palliate specific types of patients, even those who have stage 4 disease. So at the same time we've moved to less surgery in women with primary breast cancer, we've also now become more aggressive at using all the modalities of treatment for women who have stage 4 disease. Radiation therapy is used to eradicate micrometastatic disease in early stage breast cancer, and also serves a great palliative role in stage 4 disease. And we use systemic therapy, which is the treatment of macroscopic disease in the neoadjuvant setting, or micrometastatic disease in the adjuvant setting in early stage breast cancer. And we use systemic therapy to palliate and extend survival in stage 4 disease. The principles of adjuvant therapy are really important. We use the adjuvant treatment to basically eradicate micrometastatic disease. That is, a patient has her cancer removed. There's no evidence of cancer. We can't find it by any techniques, including the test that every patient wants in the West Clinic, a PET scan, which is not a perfect test, and it should be discouraged because it gives women false sense of security and exposes them to radiation they don't need in to a great extent. And we can't pick up microscopic disease today. And even if we could, we don't know which patients with microscopic disease will go on to develop cancer later. But we do know, and we've known this now for 40 years, that if you take 100 women with breast cancer who are at risk of recurrence and you give them adjuvant therapy, you can reduce the risk of breast cancer in a substantial proportion of them, of recurrent breast cancer, metastatic breast cancer in a proportion of them. And that tells us that there is absolutely a group of women who have micrometastatic disease that we are curing by giving adjuvant therapy. We have lots of different ways to use adjuvant therapy. We use chemotherapy, we use endocrine therapy, and we use biological therapy. And the research over the last 30 years have been involved in determining what the appropriate intensity and the sequence and the combinations should be. And we know a lot about this at this point in time. So we have a variety of choices for endocrine therapy, including tamoxifen, ovarian suppression, and aromatase inhibition. We have chemotherapy agents, including anthracyclines, taxanes, and non-anthracycline taxane regimens, dose-dense therapy, and we have biological therapy, which is basically, for the moment, focused on HER2-positive tumors. Tamoxifen is arguably the most important drug that's ever been developed for cancer, bar none, any cancer. Tamoxifen has saved more lives than any other medicine we use in any disease. And that's true because it's used worldwide for the last 30 years in the most common cancer. And it cures women who have estrogen receptor positive breast cancer in the adjuvant setting. Adjuvant tamoxifen is indicated for receptor positive, that's ERPR receptor positive patients regardless of age, whether they're premenopausal or postmenopausal, at any nodal status or any tumor size. The exceptions to that are women who have very small tumors and postmenopausal women who we now actually don't use tamoxifen as the standard of therapy. So I want to call your attention to this slide was from an NIH consensus statement in 2000. So 15 years later, some of this has changed, but most of it is still true. The reason we know that tamoxifen works is shown here. This is a slide that comes from the Oxford Overview, which is a collection of statisticians that every 5 years get together and poll people who have done any clinical trial with anything in breast cancer and get the patient level data, and then they put it all together. So this is actually from 5 years ago when they looked at the follow-up for women who got tamoxifen versus not. And one of the things that we learned, we didn't know in the beginning, was that tamoxifen or other endocrine therapy only works in women whose breast cancer express estrogen receptor. Again, that's 75% of breast cancer, so it's a large proportion. But as you can see, there's no benefit of tamoxifen if you're estrogen receptor negative, and a large benefit of tamoxifen if you're estrogen receptor positive at 15 years. The other important thing is to note that women in these studies got 5 years of tamoxifen, and they continued to show benefit that got better even after 5 years. So what does that tell you? It tells you that estrogen receptor breast cancer is a slow disease. Sometimes it comes back in years 5 to 10. But tamoxifen is not simply just keeping the cancer from coming back. And it's not like a dam that's keeping the cancer from roaring through. If it was, then these curves would eventually come together. The difference in these curves at 15 years shows that tamoxifen is curing patients. However, tamoxifen is not perfect, and two-thirds of the women who are at risk who will have recurrence still come back. So tamoxifen cuts the risk of recurrence by about 30 to 40%. That means there's lots of room for improvement, and we see relapses even occasionally after 10 or 15 years. So, and we've looked at other drugs which are like tamoxifen. Tamoxifen is called a SERM, or selective estrogen receptor modulator. We have other drugs like that, like raloxifene and others, but they're not really any better than tamoxifen. However, a different class of drug was developed, which is the aromatase inhibitors. It was aromatase inhibitors work differently than tamoxifen. Tamoxifen looks like estrogen at the breast cancer cell level and binds to the estrogen receptor as a competitive inhibitor of estrogen. Aromatase inhibitors work by reducing the amount of estrogen that's in the body after menopause, which is created by converting testosterone into estrogen by an enzyme called aromatase. It's the only way you can make estrogen outside of the ovary, and it happens in multiple tissues like fatty tissue and breast tissue and others. If you block aromatase, then you cannot make estrogen. So by giving an aromatase inhibitor to a postmenopausal woman, you can shut the estrogen production down to essentially zero. And that works to treat patients with micrometastatic disease whose breast cancer is dependent even on that small amount of estrogen. Aromatase inhibitors are effective after tamoxifen. They work better than tamoxifen in the first-line metastatic setting. They're well tolerated, and they don't have some of the side effects of tamoxifen, like thromboembolism or endometrial cancer. So we can weigh the risks and benefits of tamoxifen and aromatase inhibitors, and we do this in postmenopausal women. In general, aromatase inhibitors work better. They're more effective than tamoxifen by about, relatively speaking, by about 15%. So we typically start with aromatase inhibitors. And we do have certain toxicities, including a couple of the serious toxicities, like a reduction in endometrial cancer and deep vein thrombosis that we see with aromatase inhibitors compared to tamoxifen. On the other hand, tamoxifen protects the bones better than aromatase inhibitors. So sometimes we take into account the osteoporosis risk and other factors. So we're always making these decisions about what the best therapy is for an individual patient. Today, adjuvant endocrine therapy is still somewhat different between premenopausal and postmenopausal women. But we offer adjuvant endocrine therapy to every woman who's got an ER-positive tumor, with the small exception of very elderly women with very small tumors. For premenopausal women, they should be offered tamoxifen in general as their starting therapy. Keep in mind that amenorrhea is not menopause, and we don't switch to an AI until they're at least 1 year after cessation of menses, which often happens with chemotherapy. We have a new option, which I don't have time to talk about today, but that is based on studies that were released in the last year that showed that ovarian suppression with endocrine therapy is better than tamoxifen alone in selected patients, premenopausal women, and now very young women with breast cancer who have ER-positive breast cancer, like under the age of 35, or those that are at high risk with positive nodes, will get ovarian suppression with a drug like Lupron for 3 years, plus an AI, as opposed to using the standard tamoxifen. And we also know that extended adjuvant therapy is of benefit for many women. That means 10 years of tamoxifen or 5 years of tamoxifen followed by 5 years of an aromatase inhibitor in women who become menopausal during their therapy. For postmenopausal women, an aromatase inhibitor should be used at some point in the adjuvant treatment, either alone for 5 years or in a sequential strategy using tamoxifen for a couple of years, either before or after the AI. Switching based on toxicity profile is rational. In my own practice, about 20% of women who start on one AI have to switch to another AI because of side effects, typically musculoskeletal side effects. But interestingly, switching often works very well. And extended adjuvant therapy is of benefit, as I mentioned, particularly in those women that go from premenopausal to postmenopausal during the first 5 years. Let's talk now about adjuvant chemotherapy for breast cancer. Adjuvant chemotherapy for breast cancer was developed in the 1970s, and the seminal trial compared a combination of CMF versus no chemotherapy in women who were node positive. And as you can see, in a 20-year follow-up of this data, there was an over doubling of survival by giving CMF chemotherapy to women. After that, we did many other studies, which I'm not going to go through in detail, that proved that AC was equal to CMF and that anthracycline regimens were a little bit better than CMF in some cases. And what we've learned is that polychemotherapy, that is using combination treatment, significantly reduces a patient's risk of death. There is a little bit of an age dependency here, although the clinical trial data doesn't have a lot of older women, so we're not absolutely certain about that. The absolute reduction in the risk of death is better for women who have estrogen receptor negative tumors compared to women with estrogen receptor positive tumors. And node positive patients derive an a greater absolute benefit, although proportionally it's similar to women with node negative disease. But because they're at higher risk, if they have, let's say, proportionally a 30% chance of reduction, that's going to translate into a higher absolute benefit because the absolute risk is higher. So this shows this graphically, again, from the Oxford overview, that shows that women who are node negative derive benefit from chemotherapy, and those that are node positive derive a similar proportional benefit but a greater absolute benefit. And that's true for both recurrence-free survival and overall survival. So I'm boiling down 30 years of adjuvant endocrine therapy trials into one slide, and this basically shows you how we went from the 1970s to the 1990s to where we are today. So we basically knew that CMF was good, AC was good, and in Europe they used epirubicin or FEC combinations, and that begat, this is a little biblical, that begat CEF and FAC, and AC begat TC, which is taxotere and Cytoxan, which was a little bit better than AC, and AC paclitaxel, which was a little bit better than just giving AC alone by adding paclitaxel after AC, or giving higher doses of epirubicin. So we actually know the optimal dose of either adriamycin or epirubicin because we did those studies as well. TAC was better than FAC, so adding a taxane, in this case taxotere, compared to with anthracycline and Cytoxan was better, and that represents one standard of therapy today. We don't typically use a lot of TAC because it's more toxic than giving sequential therapy, but it works identically well to ACT, which is what we typically give, or we give ACP, paclitaxel. And of course, we do dose-dense therapy at the West Clinic predominantly because dose-dense AC paclitaxel was better than every 3-week AC paclitaxel, which was a direct comparison. 9741 was the name of the trial. And so that's why this has become our standard regimen. However, increasingly, we've been using AC weekly paclitaxel, and these two have been compared directly to each other and had identical efficacy, but the 12 weeks of paclitaxel and a lower dose compared to dose-dense paclitaxel was associated with somewhat less neurotoxicity. So either one of these is appropriate in the adjuvant or neoadjuvant setting. And if you want to use taxotere, that's also completely appropriate, doing 4 cycles of AC followed by 4 cycles of taxotere. These are all equivalent. In fact, all of these are equivalent. In Europe, again, they stuck with the epirubicin, and they ended up on either FEC followed by weekly paclitaxel or FEC followed by taxotere. So all of these regimens give virtually identical results. So the current status of adjuvant chemotherapy is anthracyclines, taxanes, and cyclophosphamide remain the standard. We enrolled tens of thousands of women in clinical trials to look at variations in delivery with similar results. And whether or not a 4th chemotherapy drug would work, and it did not. And so currently, the era of doing these large randomized adjuvant therapies has ended. And we don't do that anymore. And we're kind of in a situation where we don't have a lot of adjuvant clinical trials now. In part, we're a victim of our own success, which is great because many women do so well now. It's hard to do a study to try to improve a result from 95% to something better. It would take tens of thousands of women to do that. It's not a good use of our resources. So we're moving towards more biologically selected therapy. There is, of course, adjuvant trastuzumab, which is the first biologically selected therapy. And that was done with a number of trials. Once trastuzumab or Herceptin was shown in the metastatic setting to be of advantage, it was moved into the adjuvant setting. And these are just an example of 6 trials that were done looking at adding trastuzumab to standard chemotherapy, a variety different schedules as I've shown you. And this is just 2 of the studies combined, the 2 American studies that were reported originally in 2007 and then updated in 2013, which showed a dramatic benefit to adding Herceptin to chemotherapy. In this case, it was AC paclitaxel, and if you add in HER2-positive patients only, and it improved by 40% the hazard ratio, and 40% improvement in disease-free survival. There is a small cost to the use of trastuzumab, and that's cardiac toxicity. Although I would emphasize it's a fairly small cost. And if you look here across multiple trials, these are the absolute numbers of patients who had a cardiac toxicity which was clinically significant. And they're small numbers. They range anywhere from about 1% in non-anthracycline regimens to about 3% in anthracycline regimens. So judicious picking of patients for which regimen they should get and following their echocardiograms regularly has brought this number down to, in our practice, I would say, below 1% in terms of a clinical event. So today we give HER2-positive directed therapy like trastuzumab with chemotherapy to almost all women with HER2-positive breast cancer, even those with very small stage 1 cancers, even down sometimes to cancers that are 6 millimeters in size. I typically do not give any therapy outside of endocrine therapy to women who have tumors of 5 millimeters or less because they have an excellent prognosis to begin with. So the standard of care in 2015 for adjuvant chemotherapy is divided up based on the biological subsets of breast cancer. If a patient is ER positive and HER2 negative and lower stage, we'll often do a gene assay, and I'll show you that in a minute, how we use that. Most of these patients, if they have a so-called low recurrence score on the Oncotype DX21 gene assay, we will give them endocrine therapy alone. For most patients with ER-positive stage 1 or 2 breast cancer, I will give TC because there's no compelling evidence that anthracyclines add there, and TC is a little less toxic, particularly cardiac toxicity, because as you know, anthracyclines like adriamycin do have a small risk of cardiac toxicity by themselves, and that's increased with the use of Herceptin. We wouldn't be using Herceptin here. This group is the ER-positive, HER2-negative group. CMF remains a viable alternative for patients that are endocrine positive. In my opinion, patients who are strongly endocrine positive do not show a particular differential in response to different levels of aggressiveness of chemotherapy. On the other hand, patients that are triple negative, that is ER negative, PR negative, and HER2 negative, or patients that are ER positive, HER2 negative, that are higher stage, get more aggressive chemotherapy, and they benefit from more aggressive chemotherapy. Our typical, as I mentioned, is either dose-dense AC Taxol or dose-dense AC followed by weekly Taxol. For women that are triple negative and have small tumors, typically stage 1 cancers below 2 centimeters or certainly below 1 centimeter, I think TC times 4 is adequate therapy if they're lymph node negative. TAC, again, remains a reasonable option but is more toxic, and therefore we typically don't use it. For HER2 patients, they should all get Herceptin, as I mentioned, and we typically either give dose-dense AC, Taxol, or we give TCH, which is Taxotere, carboplatin, and Herceptin, which was compared to AC, Taxol with Herceptin, and was shown to be similar. We give Herceptin simultaneously with the taxane. In the U.S., we typically don't give it with the anthracycline, although I should mention in Europe they do. And then we use Herceptin to complete a year. We have done the studies to look at Herceptin for 6 months versus a year, and it turned out that 6 months was not quite as good as a year. And we also did other studies to look at 2 years of Herceptin versus 1 year, and 2 year was no better. So just by chance, because it was pretty arbitrary to pick a year of Herceptin, that turned out to be the right amount for most women. So we try to target 1 year of Herceptin in HER2-positive breast cancer. If the patient drops their ejection fraction on echo and get less, that's fine. You know, any Herceptin benefits patients. And in very low-risk patients, there's a new study that shows that weekly Taxol for 12 weeks and simultaneous Herceptin, followed by Herceptin for a year, works very well for stage 1 cancers, particularly those that have tumors between 1 and 2 centimeters. And we have been using that regimen recently because it's less toxic than giving the AC followed by the paclitaxel or by giving TCH. And the recurrence-free survival in patients who got weekly paclitaxel with small tumors is about 97%. Now, I'll just make a couple of quick comments about neoadjuvant therapy because we use a lot of neoadjuvant therapy. The basic principle of neoadjuvant therapy is to use the exact same chemotherapy before surgery as would be given after surgery. We follow these patients for clinical response by their examination and imaging. If they progress, which is an extremely uncommon circumstance, they can go on to surgery. But in my experience, that occurs in less than 1% of patients. In some cases, we can do response-guided chemotherapy, but that's not the standard. The important thing about neoadjuvant therapy, and I think I took that slide out, was that it works just as well if you give it beforehand as if you give it after in the adjuvant setting, but you can shrink tumors more with neoadjuvant therapy before you do the definitive surgery. So for women who have larger tumors who would not be good candidates for a lumpectomy, shrinking the tumor with neoadjuvant therapy can improve their chances of getting breast conservation. In addition, the pathologic complete response rate, that is when we do surgery, if we find no evidence of invasive cancer in the breast and in the lymph nodes, appears to be a surrogate for long-term outcomes. So it's a prognostic factor. And this is a study that was done and was a meta-analysis of all the studies of neoadjuvant therapy that showed that if you get a PCR at the time of surgery, in other words, you give the chemo, then you operate, and there's no cancer in the breast and lymph nodes, the outcome was better than if you don't get a PCR, and so was the survival. Very recently, the FDA approved pertuzumab, an additional anti-HER2 drug in the neoadjuvant setting for HER2-positive breast cancer that was greater than 2 centimeters or locally advanced or inflammatory in combination with taxane and trastuzumab for up to 6 cycles. And so we're using this frequently in a couple of different regimens. I want to make a couple of comments about genomics because we use this very frequently. And we're in the genomic era, which means that we don't just look at the traditional measures of recurrence risk, which are the size of the tumor, the grade of the tumor, the stage, and the age, as I mentioned to you. But we're now looking at the biology of the tumor as well. And we can do this by a variety of techniques. Of course, when we look at ER, PR, and HER2, we are looking at the biology. And so today, every patient with breast cancer all over the world should be tested for those 3 markers because it gives us subgroups of breast cancer that are different from each other in both in prognosis and in the types of therapy they get, as I've just shown you. In addition, we can do gene expression assays to get a more precise likelihood of recurrence. We estimate recurrence using a variety of different models besides just trying to do it in our head. And most recently, we've been there are models that incorporate the clinical factors like Adjuvant Online, and increasingly we use the 21 gene recurrence score assay or the Oncotype DX. Importantly, these kinds of assays like Oncotype and MammaPrint can be done from the paraffin in which the tumor is embedded, so you can go back to them at any time and do this. So the Oncotype DX test is a 21 gene assay that includes 16 genes that are cancer-related genes and 5 housekeeping genes. And it looks at the expression of these genes, meaning how much RNA is generated from the DNA. And so this is an RNA test, and it's actually technically called a PCR test. And it comes up with a complicated formula based on these genes that are then put into groups, estrogen groups, proliferation groups, HER2, et cetera. And the score is actually a 0 to 100 score that's based on how much of each of these genes is expressed by including a multiplier. And in general, in the clinical practice, the scores are almost always less than 50 if you truly have an estrogen receptor positive tumor. And this test, I want to emphasize, is only for estrogen receptor positive tumors. And it gives you a score which is lumped into 3 groups: a low risk score, an intermediate risk score, and a high risk score. And this is based on the fact that the low risk group has a low risk of recurrence. The intermediate risk group has twice the risk of the low risk group, and the high risk group has twice the risk of the intermediate risk group. The test is plotted here on a continuous variable, so this gives you the score that comes out of the tumor, and then it's plotted against the distant recurrence rate at 10 years. So it tells you about what the chance is of distant recurrence at 10 years. A low score indicates, and one other thing is that this score is validated for women getting tamoxifen. So it's ER-positive women getting tamoxifen. That's the risk of recurrence. It's based on old studies that were done 25 years ago. If you have a low recurrence score, the tumor is relatively indolent, it's sensitive to hormone therapy, and there's minimum, if any, chemotherapy benefit. In contrast, if you have a high score, it's a more aggressive tumor that's largely insensitive to hormonal therapy, but conversely, and thankfully, a large chemotherapy benefit. So in the NCCN guidelines, any tumor over 5 millimeters can be considered for an Oncotype test. And if the patient has a low recurrence score, adjuvant endocrine therapy is recommended. If they have an intermediate score, we're not sure, and they can get either adjuvant, they should all get adjuvant endocrine therapy with or without chemotherapy. And if they have a high risk score, they should get both adjuvant endocrine therapy and adjuvant chemotherapy. And this test, the major value of the 21 gene recurrence score is it's a predictive test as well as prognostic. So let's go back here for a second. This is telling you, so if you had a score of 30, it would come up here and you'd read that at about a 20% risk of recurrence. And so that is telling you the prognosis, but it doesn't tell you, and that's in the setting of tamoxifen. So the prognosis in the setting of tamoxifen actually is predictive for tamoxifen, but I won't go into that now. But its most important value is it's predictive for chemotherapy benefit. So here's a study that showed women got chemo or tamoxifen alone or tamoxifen plus chemo based on their recurrence score. And as you can see, once the score started going up high, the benefit of chemotherapy was dramatic. There was no benefit of chemotherapy in those with low scores. And this was from a retrospective study, but last week in the New England Journal of Medicine in October 2015, the first results from the prospective study of 10,000 women who were followed to see what happened when they got endocrine therapy alone with scores of less than 11 was published. And what it showed was 99% of patients, 99% of patients were free of recurrence, distant disease recurrence at 5 years if they had a recurrence score of 11 or less and got endocrine therapy, which basically means we're curing virtually all of them. I think I'll skip that. Let's go on to metastatic breast cancer and spend just a few minutes talking about this. 3 to 6% of patients have metastatic breast cancer at the initial diagnosis of their disease, and we see that a little bit more frequently in Memphis because of our population. 20% of patients with early stage breast cancer, unfortunately, despite our best efforts, will still go on to develop metastatic breast cancer. And the goals of systemic therapy are somewhat different than the goals of adjuvant therapy. Our goal is to improve survival, but we really can't talk in the vast majority of patients about curing their disease once it becomes metastatic. We can delay their time to disease progression. We can palliate their symptoms or sometimes delay the onset of symptoms. And we should also always be mindful that we want to minimize the toxicity of therapy. We certainly don't want to substitute very toxic therapy for the symptoms of their disease. Most women don't find that a net quality of life benefit. The management of metastatic breast cancer is individualized by the patient, and it's based on a variety of different factors, including first their tumor biology and whether or not they have hormone receptor positivity or not, and their HER2 status, much as it is in the adjuvant setting. It's also based on the aggressiveness of the tumor, but in this case, not necessarily based on the grade at the time of diagnosis, but the timing of relapse since their primary diagnosis, where those metastases are, whether involving visceral organs or non-visceral organs like lymph nodes and bone, and the extent or the disease burden of metastatic disease, whether they have a couple of metastatic deposits or whether they're loaded with them. Also, their prior adjuvant therapy plays a role in deciding what to do when they become metastatic. As I mentioned earlier, we not only use systemic approaches today, but we also increasingly use local approaches, particularly for oligometastatic disease, and we will use radiofrequency ablation or stereotactic radiosurgery in a lung or a liver if we have one spot. And most importantly, perhaps, are what the patient preferences are around getting oral therapy versus IV therapy, what their symptoms are, and what their comorbidities are. For the 75% of women that are ER positive, they typically start with endocrine therapy and then move on to chemotherapy when they exhaust endocrine therapy. For the 15 to 30% that are HER2 positive, they get anti-HER2 directed therapy. And for the 10 to 20% that are triple negative or ER/PR and HER2 negative, they get chemotherapy alone. And arguably, this group of triple negative is the one that we don't have targeted therapies for, but there's a lot of research going on for this. Some of the predictors for outcome for ER-positive tumor are how long it's been since they had their first breast cancer. Longer is better. Whether they got a lot of prior endocrine therapy or not. How much ER positivity there is, more is better. Whether they have bone-only disease or visceral disease. Whether they're also HER2 positive as well as ER positive. And whether or not they're also PR positive compared to PR negative, which PR negativity is a negative factor. We have many different drugs we use for endocrine therapy in the postmenopausal setting. We typically lead with aromatase inhibitors, but we have also an estrogen receptor downregulator, fulvestrant, which has a lot of use. We use the SERMs, actually typically tamoxifen in some cases. And in olden days, but still useful, we can use progestins and even estrogens themselves or androgens. And today we're testing anti-androgen therapy as endocrine therapy for ER-positive breast cancer as well. Well, what's the optimal therapy for a patient with advanced ER-positive breast cancer? We have a lot of options in the metastatic setting. For premenopausal women, we typically do ovarian suppression or ovarian ablation by oophorectomy, and then typically start an aromatase inhibitor or tamoxifen. Postmenopausal women get an aromatase inhibitor or fulvestrant or tamoxifen, and increasingly we're using combination endocrine therapy and biological therapy. We have a new drug called palbociclib, which is a CDK4/6 inhibitor that works in combination with aromatase inhibitors and improves progression-free survival. We have another drug, everolimus, which is an mTOR inhibitor, which in combination with aromatase inhibitors also improves progression-free survival. So increasingly in women who, particularly first or second line, who are younger and can tolerate combination therapy, they're becoming very useful. Cancer chemotherapy has been around since the 70s in metastatic breast cancer. The development parallels that I showed you in the adjuvant setting. We use the same drugs, and we've done many different studies to try to figure out which is the best treatment. As it turns out, taxanes are the most active class of drugs, but there really aren't that many differences. Both paclitaxel and docetaxel are similar, but they're used differently. Docetaxel used every 3 weeks as the best schedule. Paclitaxel used weekly in the metastatic setting is the best schedule. In general, the recommendation for advanced or metastatic breast cancer is to use sequential monotherapy, except when there's a patient who presents with life-threatening visceral metastases or rapid clinical progression or the need for rapid symptom and or disease control, because the response rates are higher for women who get combination therapy, but so is the toxicity. We usually give each regimen for as long as we can until the patient progresses or develops unacceptable toxicity. There is no single agent outside of the taxanes and arguably the anthracyclines, the two most common the two most active groups of drugs that we use. After that, there are really no head-to-head comparisons of the agents that we use every day, including gemcitabine, capecitabine, navalbine, and Doxil. And the response rates and the time to progression are similar across these different agents, about a 30% response rate with a median progression-free survival time of 5 to 8 months. So the recommendations are to choose the drug by the patient preference and toxicity profiles. And this gives you an example of the different classes of drugs and the preferred single agents by NCCN recommendations, as well as other single agents. And there's a whole long list here, as you know. In addition, there are some combination regimens that can be used. A couple of these have been tested in phase 3 studies, like docetaxel and capecitabine, which had a survival advantage over docetaxel alone, and gemcitabine and paclitaxel, which had a survival advantage over paclitaxel alone. We rarely use those, however, today. In general, again, patients do best with their first-line therapy, less good with their second-line therapy, and less good with their third-line therapy. We really have very little data for fourth-line therapy or beyond, despite the fact that many patients with breast cancer with metastatic disease get 6, 7, 8 lines of therapy, sometimes with very meaningful benefit. So there's no single gold standard for chemotherapy in metastatic breast cancer. Usually anthracyclines and taxanes should be used as the first-line option. The therapy should be individualized based on the goal, the tumor, and the patient characteristics, and we use many lines of therapy now. We have trastuzumab for HER2-positive breast cancer, which is a monoclonal antibody. This is the first trial that showed that trastuzumab works in a targeted group of patients, those that have HER2 overexpression, but didn't do anything in women who had HER2-negative disease in this study, as shown by FISH negativity. The natural history of HER2-positive breast cancer used to be the worst group of patients, used to be worse than triple-negative, and it's now the best group of patients, as you can see here in this gray line that shows it's actually better than women who had ER-positive breast cancer. And the average, and this slide is actually a few years old, so the average survival for women with HER2-positive breast cancer is getting longer and longer, and that's because we know the target and we have therapies against the target. And two quick examples of this is the Cleopatra study that added pertuzumab, another anti-HER2 agent, to trastuzumab and chemotherapy that showed a survival benefit. And you can see that the survival benefit is actually over 3 years. This is first-line patients with metastatic HER2-positive breast cancer. Over half of them are living over 3 years. And we also have new drugs like TDM1 or Kadcyla, which is a antibody drug conjugate, which is like a smart bomb where you have the chemo connected to the trastuzumab and it's released in the HER2-positive cell. And this shows that in the second-line setting that there was a survival advantage to single-agent Kadcyla compared to capecitabine and lapatinib, another combination that's approved in HER2-positive breast cancer. So what are our remaining problems? Well, as I mentioned, triple-negative breast cancer is a problem. We have multiple subtypes, however, of triple-negative breast cancer, and we'll understand this disease much better in the next few years, I believe. Platinum agents probably do play a role in some sets of triple-negative breast cancer, and PARP inhibitors for BRCA-mutated breast cancer may become useful. CDK4/6 inhibitors are now approved. Brain metastases remain a big problem, but there are some new agents being tested. So my personal approach to metastatic breast cancer is, if possible, to still put a patient on a trial first. Despite the advances in all subsets of breast cancer, these women still die of metastatic breast cancer. We can do better, and the only way to do better is to enroll women in clinical trial. I always rebiopsy the metastases because there's about a 10 to 20% chance of a phenotypic change. That means it could go from ER negative to ER positive or HER2 positive to HER2 negative. And we see that not infrequently, so a biopsy is important. If a patient is the 3/4 of patients that has ER positive disease, I will start with endocrine therapy. Frequently, we can get up to 3 lines of endocrine therapy in a couple of years of giving treatment that is relatively non-toxic before we have to move to chemotherapy in those patients. When we move to chemotherapy, either in the triple negative or the HER2 positive or the endocrine therapy patients who have exhausted endocrine, or the ER positive patients who have exhausted endocrine therapy, we move to anthracyclines and taxanes, or single agent, any one of these agents. They all work about the same. If they're HER2 positive, they get Herceptin, Perjeta, and taxane first, and then T-DM1, and we have other drugs as well. So that is the end. That was a whirlwind tour of all of breast cancer. Now everyone's an expert and hopefully can pass your boards. So thanks for your attention.